Good evening, and thank you for joining us on our bi-weekly call with Dr. Cameron Kaiser. Uh, I, I preface each one of these meetings. I am so grateful to Dr. Kaiser, myself, and my family for help keeping us safe. His leadership has been outstanding in all this, and I know he's got a plate full, uh, especially over the last couple of days with our schools trying to open and which way our schools will be opening. So without further ado, I'd like to introduce Dr. Kaiser here. Do you have any words at all here before I start asking the questions tonight, Dr. Kaiser?
Oh, actually, I've got quite a lot.
I figured you would.
Yeah, I think there's a number of topics we'd like to cover. First of all, the statewide data situation, of course, our recent serology study, and school reopening or not. So some of these are questions that people have asked tonight. I will try to do the high level here, and then we can fill in some gaps later on.
Okay.
Our current numbers are 39,741 confirmed cases with 770 deaths. However, this case number is universally believed to be lower than actual because of issues with CalReady, which is the statewide communicable disease tracking system. To explain what's wrong, let me first discuss briefly how communicable disease reporting works in California on the back end. All cases of reportable illness end up in CalReady by regulation. This is, in fact, how we as a local health department inform the state of disease counts in our individual jurisdictions. And in turn, we can use CalReady as a data warehouse for running reports and tallies. You could even think of it as a specialized form of health information exchange, just one tailored for public health purposes, where the state is the only one that has the global view. Some jurisdictions prefer and do use their own systems for receipt. They send in batch secondarily to CalReady to populate that database, but most of us just use CalReady because it's already there. Likewise, manually entered reports, such as from confidential morbidity reports that you as clinicians send in, or various point of care testing, are in fact the minority, actually, of what goes into CalReady. The vast majority of results that are processed are actually large volumes from high throughput clinical labs, notably the national ones like Quest and LabCorp, under a process which the state calls electronic laboratory reporting, or ELR. The exact failure is the piece connecting ELR through to the main CalReady data repository. This involves a product which will be familiar to some of you called Rhapsody, which is the software handling the message passing. I saw that look, Dolores. You are very familiar with Rhapsody, I'm sure. There is little redundancy in this process, and there was a whole lot of bounced duplicate messages from laboratories participating in ELR. This turned into system delays while the system tried to bounce those back off. This piled up legitimate messages apparently sometime last week. We ourselves in the county started to notice that there were a large number of duplicates, and then saw our predicted curves, which generally have been underestimates, showed some rather quick and surprising declines. The state determined the problem, and to be honest, this probably already existed to some degree, but never previously reached this point. And they have escalated to the vendor, but we do not have an ETA. And because of the redundancy issue, we are iterating on a means to get results from the labs in some sort of batch, possibly as low tech as an encrypted spreadsheet if we have to. But we'll still have to enter those manually into CalReady and to continue feeding our normal data group workflows. We had a rather helpful meeting with one of the state data analysts today. They're trying to get some samples of our information to compare with theirs to determine what's out there and what still needs to be recovered, and then hopefully we can try to replace it. The upshot of all this is that anything directly derived from CalReady data, which for us is our cumulative confirmed count, case rates per 100,000 population, positivity rates, doubling time, and number of tests performed, should not be considered reliable until further notice. We are currently estimating that the state system is dropping about half of the tests being run. We don't believe the vast majority of the data is irretrievably lost. Part of the conversation we have with them today is to figure out how much. We think most of it is recoverable. But this still has a serious impact on callbacks and contact tracing because that has to be done on a timely basis. We will now lose the opportunity to isolate new cases early and slow down transmission. The numbers that we do get and are able to act upon are primarily actually through EPIC. That serves as the county health platform and is where the county-run testing sites deposit their data. And we are also able to do some manual entry, so we are working with those to the best extent that we can. Three figures, however, are not affected by this, and they are total COVID-19 positive hospitalized cases, total COVID-19 positive ICU cases, and COVID-19 associated deaths. Hospitalization data are determined directly through hospital survey, and this is conducted separately of CalReady. And because those results are being queried from the individual hospital's health information system, we consider these to be sufficiently reliable. However, the decreases in hospitalization, and they are generally attributable to recovery due to the hard work of everybody on this call, are unfortunately also due to deaths, which because of improved management and pharmaceutical options are extending the death time lag to about 4 to 5 weeks. I am personally aware of a significant number of fatalities which are in the queue and working their way through the system for confirmation. We expect that these deaths are part of the July 4th spike in cases, and we do not want another on Labor Day. Death data likely comes from both the hospitals and from the coroner's office, and for the numbers in play, fortunately, this is still a largely manual process. Like I say, our conversation with the state as of today indicates no specific ETA for repairs, but that does lead into the school discussion because the case rate is one of those benchmarks for transitional kindergarten through grade 6 waivers. Currently, the state does not allow schools to open for in-person instruction for counties on the statewide monitoring list, which we expect to remain upon for an indefinite period due to the CalReady situation and the subsequent expected spike in cases, except for TK through 6, which may open even in monitored counties with a waiver granted by both the local health officer, i.e. me, and CDPH. The situation with pediatric COVID-19, and I'm sure the PEDS and FPs on this call will appreciate it, remains highly controversial, and there have been outbreaks in summer camp situations, which proves that transmission is possible. Previous studies suggesting school transmission was of minimal risk were limited by the fact that most kids were not tested if they were asymptomatic, and most clinicians believe that at least in the short term, most kids tolerate COVID-19 infection rather well. The theory is based on relatively low expression of ACE2 receptors in younger age ranges, though this theory is still somewhat speculative, and it doesn't necessarily mean they can't transmit it. There was a well-publicized German study and a couple recent confirmations that showed that their viral load, even in young children, is still proportionately similar to that of adults. And when schools are exhaustively tested, it turns out student-to-student transmission does indeed occur, albeit subclinically. There is a South Korean study, which is currently, I think, the highest quality evidence available. It suggests that while older children and teenagers may transmit as well as adults, and possibly better, depending on personal habits, children under 10 do seem to have lower risk. Based on their greater need and benefit from in-person instruction and perceived lower risk of student-to-student and student-to-staff transmission, CDPH does permit waivers to be issued even in monitored counties like ours, as long as the case rate is below 200 per 100,000 residents. Since CalReady has frozen that number, we are frozen at 202. San Bernardino is at 238. And if we're going to take the over-under on what's going to happen when CalReady gets unblocked, it's going to go up, not down. We therefore will accept applications when the county rate is reliable and below that threshold, and there is no provision for regional subdivision. Even when we do review waivers, my goal here is, I don't want to put too fine a point on it, but since there will be interest from many to see some schools open, I might as well make political necessity into a virtue and learn something from that process. But it's going to have to be a controlled environment before we learn anything. What I'm considering looking at, depending on the applications we get, is to cap the number of waivers we issue. And schools will be required to present a response plan, a cohorting plan to keep kids in stable groups for contact investigation, and an every 2-month plan to test staff. That testing plan can't be me as the county, because what services I offer to one school, I have to offer to every school. And with the number of counties out there, that just isn't feasible. We did make our announcement yesterday so that schools understand the situation. and offer means of technical advice so that they can have their applications ready and I can assess interest levels to determine what level of phase-in is required. But until then, no formal waiver applications will be accepted until we're below the benchmark, and all schools must remain on distance education until then, or should we precipitously exit the monitoring list through some undefined miracle. Last but not least, let me say a few words about the County Cerro Prevalence study. We modeled this on Los Angeles County's study done through their Department of Public Health and the University of Southern California, which is to say we shamelessly ripped off their study design with their permission. We tried to recruit about 2,800 county residents adjusted to region and population. We got 1,722, which I thought was actually a pretty good response rate. And then 101 of them tested positive for antibodies to SARS-CoV-2, translating to a raw prevalence of 5.9% with a 95% confidence interval between 4.8 and 7.1%. Fewest cases regionally were found in South County at 2.6%, and the most in Central County at 7.5%. Note that this is higher than LA County study, which came in somewhere around 5. But remember also that we are a blood draw assay as opposed to a laminar flow point of care study. So we may have actually had better sensitivity as a result. I think we used a fairly good assay for that reason. And also we did this later in the pandemic when we presumed that there may have been a greater prevalence at that time. Nevertheless, this translates to around, based on our population of 2.4 odd million, around 119,000 to 175,400 residents have been infected, and computes out to a rough infection fatality rate between 0.36% and 0.54%. This indicates that the vast majority of Riverside County residents have not been infected, and that if herd immunity is a thing, and this is absolutely far from certain, then we're going to have to see a whole lot more deaths before that actually happens. Recall that flu has an asymptomatic presentation as well, and its infection fatality rate may be as low as 0.01% on that basis, as case fatality rate is widely reported as 0.1. But if you're going to give an apples to apples comparison, you have to include those cases, and they too diminish their infection fatality rate substantially. With that sobering thought in mind, I will hand it back over to Dr. Holmblatt for the questions.
Thank you for your 30,000-foot overview of our situation here in Riverside County. So question number one, even though hydroxychloroquine has been proven to have no effect for COVID-19 treatment, some physicians advocate it. What is the newest recommendation for the use of hydroxychloroquine in the treatment of COVID-19?
As of July 1st, the FDA has concluded, and this is its current position statement, that based on significant safety issues with hydroxychloroquine and chloroquine, most notably including QT prolongation, but there are others, it should not be used outside of clinical trials for this purpose. Where clinical trials are unavailable or participation is infeasible, don't use it outside of a hospital. The FDA statement actually is quite clear, and I quote, hydroxychloroquine and chloroquine have not been shown to be safe and effective for treating or preventing COVID-19. Now, keep in mind also, particularly for rheumatologists, this does not apply to their more typical indications. Patients taking hydroxychloroquine or chloroquine for FDA-approved indications to treat malaria or autoimmune conditions should continue taking their medication as prescribed. The benefits of these medications outweigh the risks at the recommended doses for those conditions.
Okay. Question number two, what is the status of opening schools in our county this fall?
Unlikely given our numbers, but I think I kind of beat that one to death in the prologue. So why don't we hit number three?
We will hit number three. Some of the private schools have indicated they have received an exemption and are opening for in-classroom right after Labor Day.
Yes, we are aware of that. Several of them have made this quite public. So let me say clearly and unambiguously in response that as of right now, and I can't see this happening in the immediate future at the minimum, no exemption has been granted for any school in Riverside County, public or private, and even mere applications will be accepted only when the case rate comes down below the threshold. If they claim they have an exemption from the county or state, that is false. And if they are grade 7 and up, they can't even get one. Should any of them actually open and start populating classrooms, we will notify the state.
Okay. Are exemptions being granted? I think you beat this one up too. If so, what safeguards are required, and how will they be monitored?
Like I say, we're going to require them to present certain aspects of their plan. I want to see their 2-month testing plan. Their staff must be tested every 2 months. I'll want to see their response plan, how they're going to get results, not only from their surveillance testing, but also when they find out a case back to us. And we're also going to want to find out their cohorting plan, because part of the school K through 12 framework requires them to put students, and for that matter, teachers as much as possible, into stable cohorts, so that way we have control, hopefully, if there is an exposure, and limit it to that specific cohort. There are state benchmarks that indicate whether a school must close. If a school exceeds those, it will be ordered to close either by me or by the state health officer. If they fail to close, then enforcement actions will be taken.
Okay. Question number 5. Is there a centralized location that healthcare workers can go for COVID-19 testing that will expedite results?
Presently, no, but that's primarily for the expedited part. Assuming that you aren't sending them there until they get a negative result after they tested positive, because we consider that to be retesting and clinically inappropriate. Healthcare workers are always welcomed at any county location. Just have an appointment before you go. However, expedited results are entirely done through our own public health laboratory because of capacity issues at the national labs. We ourselves have a volume contract with LabCorp, but Quest has had similar problems. And our public health lab itself has a limited capacity because of the national reagent shortage and our ongoing lab expansion project, which of course we chose to undertake shortly before the worst pandemic in over 100 years. Before that reason, we have limited the PHL to high priority results such as first responder clearance and high risk outbreak settings such as testing of congregate living facilities, skilled nursing homes, and so on, so that sufficient spare capacity is available if we have to mount multiple responses. We regret that because we're essentially at the mercy of LabCorp's turnaround, we just can't make any guarantees on timeliness, let alone within an expedited time frame. If this is something absolutely mission critical to you and you need a diagnosis grade result, reason I clarify that is that there is more interest in antigen testing. Even though antigen testing's got its drawbacks, it probably has poorer sensitivity than PCR, and at least some of the assays have had some fairly public issues with specificity. Nevertheless, it may still be useful in a surveillance situation if you're in one of those circumstances where you have to test your staff over and over multiple times. For that reason, since they're going to be retested, that could be an option for you. But if the result has to be diagnosis grade because you really do need to know, then it's going to have to be PCR, and you may have to set up such a contract yourself to get timeline guarantees. What I can do, though, is I will provide Dolores after this meeting with a link to the statewide testing task force list. This is designed to be public facing. It is not just for the use of local health departments. Anybody can use it. In fact, I sit on this along with the health officer from Del Norte County. So talk about opposite ends of the state there. And we both asked them to make sure this is something that we can present to people who want to use it as a testing resource, precisely because the county cannot be the testing resource for absolutely everybody in Riverside County. There is no way we get that kind of throughput. But we would want to make sure, though, that the people who should be testing have at least some means to do so, and that can give you a potential outlet.
Okay, thank you. Question number 6 is CalReady our single source of truth we use to manage COVID-19 in Riverside County? Can you update us on current state of affairs as to testing, including types of tests, sites update, results, turnaround, and contact tracing?
We talked sort of about CalReady, and unfortunately for Riverside County, CalReady is pretty close to our single source of truth. As a result, it is almost impossible for me to say right now exactly what the test results turnaround is because I don't have any ELR set up consistently. I can say for things that move into Epic, I think they're back down to around the 3 to 5 day level, but that doesn't necessarily correlate with what you may see on the ground. Similarly, contact tracing is trying to do the best they can with the limited number of cases that we do have visibility into. Even though the lower number hopefully will enable us to investigate these contacts more completely, we also know this is again, at least no more than 50% of the cases which are out there, so we're missing a lot of opportunities, and that will unfortunately translate into an inability to prevent further transmission, at least for those individuals. Until we get this fixed, unfortunately, I don't have anything better to say in that regard.
Okay. Question number 7, and you may have gone over this already. Yeah. I guess I would just ask, are the positive numbers truly declining?
No. I think they are, because our hospitalization rate is not sustaining. We had that sharp rise, and then now the deaths have been occurring, and that, of course, is unfortunately bringing down hospitalization the wrong way. But the vast majority of people are still leaving the hospital okay. It is not going down as quickly as I would like it to, so therefore we must assume that people are still newly being hospitalized for this, but at least the impact on hospitalization does not seem to be sustaining, and that suggests that transmission is also going down. I don't know that for certain, but at least that gives us some hope that that may be true. Short of that, we're just going to have to wait and see what happens with these numbers. As I say, though, my biggest worry is our next holiday weekend over Labor Day, and I do not want the same thing to happen that we already saw happen on both Memorial Day and July 4th. I think we hit 8, but why don't we jump to 9, because there's a dimension on that question I'd actually like to address specifically.
Okay. If there is indirect exposure to a COVID-19 positive patient, do you need to get tested even if you are asymptomatic? And do you have to self-quarantine while waiting for the test results?
So I guess this depends greatly on what you call an indirect exposure. The CDC definition of exposure is less than 6 feet apart for more than 15 minutes where one or both parties were not consistently masked. Now, one thing I always clarify this with is, do not interpret this to mean that if both parties are masked, I will never consider it an exposure. Just understand I am much less likely to. If you mean by indirect one of these sorts of wobbler or borderline type exposures, if it still meets the criteria, you should still treat it as an exposure, even if you don't think it happens to be particularly extensive. If you remain asymptomatic, I would not test you before day 7 to ensure a reasonable level of sensitivity, given the median onset of symptoms around day 3 to 5, but you should still complete the full 14-day quarantine regardless. If, however, by indirect you mean that you were exposed to a contact rather than to the case, the broken record that I played for about all of March and April was we don't quarantine contacts of contacts. If you are concerned, by all means, go and get tested. The county still does see and test asymptomatic individuals. Just be aware that the yield is less. But I would not necessarily demand that you go on quarantine unless you had symptoms, which you shouldn't be working when you're sick anyway, or the contact that you had contact with does turn out to be a case, and this was within the 48 hours before they were symptomatic or before they were tested, whichever is earlier, which would be considered their infectious period. In that case, then the usual advice still applies. I do point out for the record that given our prodigious spread in Riverside County, and I think I will conclude on this note, at this point in the pandemic, you are increasingly as likely to be infected outside of the office as you are to be infected inside of it.
All right. We have one question out of the chat room. Do you have time to answer that? Or
I've got a few minutes still.
Okay. Thank you. This is from Dr. Rajaratnam. What type of social distancing, masking, and hand washing sanitizer use will you be recommending for the schools as a requisite for opening?
We will generally be requiring pretty much everything that the state does in their framework. Short of that, and I'm pulling it up to give you all the exact list here. I just had it here and it disappeared. Just a moment, I'm sorry.
That's all right.
Currently, the CDPH recommendation, they would like face masks or face shields for very young children, ages 2 or older, so that those who cannot manage masks can nonetheless be protected. And CDPH guidance requires that all children in 3rd grade or later to wear a mask, and we would mandate this of all schools that reopen under the waiver program. Other countries' experiences actually suggest virtually all students can be taught to handle face coverings at that age, so we're fairly confident that this can be achieved. Masking and hand washing procedures will also, hand washing and sanitizer use. They need to have a plan for cleanliness of the classrooms and spaces, a disinfection plan for responding to a potential exposure. This is not necessarily prescriptive. This will obviously vary based on the space that they're in and the nature of the specific space. And nevertheless, all of them are required to at least demonstrate they've thought about it. As far as social distancing, we are asking that the full feet of 6 feet should be applied in a classroom setting as much as possible. We acknowledge that 6 feet of physical distancing isn't always practical on things such as school buses, but that's why we have the facial coverings there, because we like a multi-layered approach. There are no recommendations necessarily for smaller class sizes. A number of schools have said, well, we have very small classes, we should be able to qualify for a waiver under that basis. Sorry, the state doesn't enable an exemption to the 200 per 100,000 rule based on attributes of the individual school, but we may consider your plans to reduce class sizes as part of the application during the waiver process, even though we're not necessarily mandating it, as long as you can achieve requisite social distancing within whatever classroom space you use. I should also point out for the record that either I or the state can veto a waiver. Even though both of us have to agree on it, either one of us can shoot one down. So there is a built-in check in the process, and virtually everything that we receive must be reviewed through them before it goes forward to make sure that they have no concerns about the application and the nature of the school which will be reopening. Are we assuming a lot from these schools? Yes. And I don't suffer any illusions that there are probably more than a few schools who are so desperate to be open, they'll pretty much tell us anything they can think of to get open. I'm not blind to that potential. Nevertheless, however, if they at least make a plausible attempt at it, and our rates are low enough, and we believe that they have sufficient safeguards in their process that they can police that, then there may be some possibilities there. But nevertheless, I do realize that we're walking into a situation which is fraught with a lot of political landmines. Yesterday's letter really upset a number of schools who assumed they were going to be given a waiver automatically, which is never the message we gave them. And yesterday's letter basically told them until further notice they're not getting a waiver at all. You can imagine that unsettled quite a few of them, and the supervisors' offices have been lit up about that. Nevertheless, however, we are going to follow what the state guidance says. The direction of the Board of Supervisors is always to align with the state guidance, and we're going to do it. And we're going to make sure that whatever schools do open, we don't open in such a way that causes a catastrophe or more issues that occur at once than we are able to respond to.
Okay. I think we had one more question here that I overlooked about telehealth. Is it okay to continue telemed at this time? Can we do Medicare preventive visits on phone call?
I think that's a Mitzi question, isn't it?
I think it is a Mitzi question. I just threw that out there. I thought maybe that was also for you, but it sounds like a Mitzi question. So,
right, Dr. Holmblad.
Yes.
If I could just jump in, and we did get that question, and it definitely is not a Dr. Kaiser question, and that's why we indicated that there's 2 resources that we have on the RCMA website that answers and gives guidance to all of the telehealth questions and concerns. And then there's also the slide deck from a webinar that we gave that provides additional guidance and answers of these type of questions. So people can look on the RCMA website using these links, and everything you ever wanted to know about telehealth is in there.
Okay. Well, Dr. Kaiser, thank you very much again for your informative half hour. I will tell you that, well, you really pack a punch here in 1.5 hours. I learned so much every time I listen to you. And once again, I'm speaking for multiple members of our county. We really do appreciate your help, and we support your decisions. Thank you again.